Okay, we'll return to Unit 7 on capnography, and we'll talk about what the measurement is affected by. So there's about 5 things that will affect the measurements of capnography. One would be moisture, so if there's any moisture in that cuvette or in that sensor, that will affect it. Barometric pressure, so just like our PiO2 calculations that we did back in semester 1, anytime you're going up or down in barometric pressure, it will affect the readings of the capnometer. Temperature, so remember that we have to heat the mainstream capnometer. Vibration, so if there's a lot of vibrations either from the ventilator or mask or anything that the patient's using, that could affect the reading. And then mucus in the sensor, so if there's any mucus in that sensor, either side stream or mainstream capnometer, it will affect the reading of the carbon dioxide level. So what are some causes of an increase in end-tidal CO2? So a lot of it's going to be the same type of things that would cause our P little a CO2 to rise, will also cause an increase in our end-tidal CO2. So one of those would be increased cardiac output. So if we have increased cardiac output, we have increased CO2 coming back to the lungs, so that will rise our end-tidal CO2. Hyperthermia is another reason that end-tidal CO2 will rise. Hyperthermia means a higher than normal body temperature. Fever will cause end-tidal CO2 to rise. If a patient is septic, they'll have an increase in their CO2 level. An increase in metabolic rate, decrease in alveolar ventilation. So this is the one we kind of think of when we're talking about PaCO2. So if their alveolar ventilation decreases, then they retain more carbon dioxide. Respiratory center depression, that will again cause a decreased alveolar ventilation in most cases, so that will cause an increase in CO2. Muscle paralysis will cause an increase in CO2, especially if we have a diaphragm muscle paralysis. Hypoventilation, so hypoventilation is either breathing at a lower respiratory rate than normal or breathing at a lower tidal volume than normal. So either one of those cases will cause hypoventilation, and that will cause our CO2 to increase because we'll be retaining carbon dioxide. And then COPD patients, remember they have a normally high carbon dioxide reading, or PaCO2. So if their PaCO2 is high, it will also cause an increase in end-tidal CO2. And that's because of all of the air trapping that occurs in a patient that has COPD. Some causes of a decrease in end-tidal CO2. A reading of 0 usually indicates that you either have a system leak, esophageal intubation. So if you're intubated in the esophagus, you're not going to get any carbon dioxide returned back to the monitor. If the patient is apneic, same thing. They will not have any carbon dioxide going back to the monitor. An airway obstruction, such as a blocked endotracheal tube or cardiac arrest. In all of those cases, you're probably going to see a 0 reading because you're not getting any carbon dioxide back, going back into the monitor. Decreased CO2 production and delivery to the lungs, and this can be caused by hypothermia, which is a lower than normal body temperature. Pulmonary hypoperfusion, so if you're not getting as much blood flow going to the pulmonary system, you're not going to have as much carbon dioxide being exhaled. Pulmonary embolism, this one is highlighted. Pulmonary embolism will decrease their end-tidal CO2. Their PaCO2 may be normal, but their end-tidal CO2 will be decreased. So that would be one that you would probably want to highlight and star. Hypotension is another reason for a decrease in CO2. Decreased cardiac output, again, if you're not getting as much cardiac output to the body, then you're not going to be bringing back as much carbon dioxide to the lungs. Hemorrhaging, hyperventilation, again, this is one that we think of when we're talking about PaCO2, and hyperventilation will decrease our PaCO2. It will also decrease our end-tidal CO2. So hyperventilation is either breathing with a high respiratory rate or larger tidal volumes, and so you're blowing off too much carbon dioxide. Ventilator disconnect, if you become disconnected or the patient becomes disconnected from the ventilator, the reading will drop on the end-tidal CO2 monitor. Air embolism will cause a decrease in end-tidal CO2, and any type of cuff leak through the endotracheal tube will have a decreased end-tidal CO2 reading on the monitor. All right, so we're going to go through each point of these normal tracing. This would be a normal tracing on a capnograph. So point A is the beginning of inhalation. So we have to remember that this is measuring carbon dioxide, and so in order to get carbon dioxide, the patient is exhaling. So the graph is showing exhalation. But if we start at point A, that is the end of inhalation, so there's not going to be any carbon dioxide present. Point B is where we actually start to exhale. And when we start to exhale, it first comes from anatomical dead space. So part of the ventilation that does not participate in gas exchange. So because it's not participating in gas exchange, it will start at a reading of 0 because there's no carbon dioxide present. And then from B to C, we have this steep incline. This is where there's a changeover from dead space to alveolar gas. So now we're not only exhaling from dead space, but we're also starting to exhale from our alveoli. So our alveoli will have carbon dioxide in it. So when we get to this point between B and C, we're going to see a sharp upstroke. And again, we are switching over to dead space into alveolar gas at this point. And then C to D, we're going to kind of have a little plateau. And this is gas that's being exhaled entirely from the alveoli. So remember, B to C was a mixture of dead space and alveolar gas. This plateau from C to D is only gas that's being exhaled from the alveoli. Point D, you might want to circle that one. That is our end tidal CO2 reading. So that's the number display that's going to be on the machine. And then from D to E, we start to inspire again. And that will continue all the way again until point A. So again, A, we're starting to end our inspiration. B, we're only expiring gas from dead space. B to C, we have a mixture of dead space and alveolar gas. C to D is just gas that's being exhaled from the alveoli. Again, D is our end tidal CO2 reading. And then D to E, we start to inspire again. All right, so looking at the graphs, we can very quickly look at the tracing and decide which clinical variation it belongs to. So if you look at this first tracing, we have carbon dioxide. The first one looks like it's a pretty normal capnograph. And then as we go along, the CO2 levels start to decrease with each breath. So this would be something that you would see if somebody was hyperventilating or hyperventilation. Either their respiratory rate's too fast or their tidal volume's too big and they're blowing off an excess amount of carbon dioxide. So you'll see here the percentage of exhaled carbon dioxide is decreasing. And actually on this graph we have it, our reading in torr, so we can even look. The first tracing goes up to about 40 torr. The second one is maybe at 39 torr. The third one's about 30 torr. Fourth one, again, maybe 29 torr. And then we're going to about 20 torr. So our CO2 level is decreasing as we go along that graph. Our second clinical variation would be hypoventilation. And remember, hypoventilation is either a slow respiratory rate or a small tidal volume, so you're retaining more carbon dioxide levels. So for this one, your CO2 levels will start to increase. So if you look at the first tracing, again, we're right at normal at about 40 torr. Our second one goes up to maybe 42 torr. The third one looks like it goes all the way up to about 50 torr. So our CO2 levels are increasing with each breath on that tracing. Our third clinical variation is rebreathing of carbon dioxide. This results in the baseline carbon dioxide level increasing above 0. So this would be somebody who either has some air trapping or we're not giving them enough time to exhale fully on the ventilator. So you'll see here this tracing. The first one looks pretty normal until you get to the bottom, and it does not go all the way back down to the 0 baseline. So all of those should go back down to 0 if we're giving the patient enough time to exhale during each breath. If we don't get down to the 0, then we need to do something, maybe decrease their I time so that we can increase their E time, decrease their tidal volume, increase their flow. There's different things that we can do if somebody's not returning back to baseline. The next clinical variation is a ventilator disconnect or apnea. So in spontaneous ventilation, it's indicated by a sudden loss of the capnogram. So if you see here, we were going along just nicely with this first one, and then all of a sudden we just lost the tracing altogether. So that would either be the ventilator became disconnected from the endotracheal tube, which does happen every once in a while, or the patient went apneic. So either of those, especially if they are spontaneously breathing and we're just monitoring their end-tidal CO2, apnea would be a big concern. The next one kind of depicts what would happen, or what you would see if somebody's in cardiac arrest or has hypotension. So for this one, a rapid progression, progressive decay in the plateau is noted during cardiac arrest or severely developing hypotension. Because of loss of perfusion, dead space markedly increases and carbon dioxide decreases. So if you can see here, this first one looks sort of normal, but then you start to lose the plateau and you just have these rounded tracings. Especially the second one is a good indication. So that would be cardiac arrest or hypotension. The next one is a spasmodic contraction of the diaphragm. A spasmodic contraction of the diaphragm, or the interruption of exhalation by an incomplete breath. So a spasmodic contraction of the diaphragm is just a fancy way to saying hiccups. So if somebody has hiccups, you'll see kind of this notch in the top of the capnogram tracing. All right, when you're looking at interpreting different tracings on capnography, the things that you want to evaluate are height, and we'll go through each one of these separate: height, contour, baseline, frequency, and rhythm. So those are kind of the 5 things that you look at when you're doing or looking at different clinical variations or different clinical tracings. All right, I'm going to stop this video, and this will be video 2 for lecture, and I will do one more video. We should be able to finish up Unit 7 with one more video. So we'll pick up from here on the next video.